I want to talk about frozen shoulder.
Yes.
I saw this in practice all the time, way more frequent in women than in men. Talk to me a little bit about, and you mentioned already some of the adenocarpal capsulitis that happens
Yeah.
when we see the decrease in estradiol
Yep.
in our going through menopause. But talk to us about what you're seeing in your patients when
Yes.
you're operating them on the OR in the operating room, and what are some of the signs and symptoms of frozen shoulder? Yeah, let's start there.
So, first, I want to clarify frozen shoulder can happen in men and women. It is an inflammatory process. So, people, men and women, with diabetes and out of control blood glucose and hemoglobin A1Cs off the charts 7, 8, 13, I've seen 14, 15. Such highly inflamed people, the inflammation is what aggravates the capsule of the shoulder. Now, add on top of that, losing your estrogen, which protects us then from inflammation. Women who come to me in midlife, I had 4 women on Thursday come with this, say things like, my shoulder is excruciating. I did nothing. I didn't hit it on anything. I didn't do any activities and it won't move. And they'll show me. They're like, this, it doesn't move, it's down below my waist. And they can't hook their bra. Internal rotation with your hand behind your back is actually the first motion that people lose. That's what people come to me saying. When they say that to me, I do not take up that conversation right away. I start talking about perimenopause to frame for them why they are like this, because the first instinct is that they heard it or did something wrong. That's number one. So then once I return to the shoulder, I try to move it for them. And often it's almost like there's a physical block to motion. I try to move it in forward flexion and internal rotation. Well,
And this is in the freeze phase. Like they usually, people don't, so there's, for those listening, there's usually 3 phases that we talk about with frozen shoulders. Like, I think it's freezing, frozen, and then the
thawing.
recovery is called
Thawing.
which is funny.
But
yeah.
the irony is that you're really hot and red inside. Not right. It's opposite.
You're not cold. It's not cold at all.
It's not cold. Fire and ice. It's the fire. Right.
Yeah.
So when people are freezing and in the frozen stage, it won't move. But this thawing period can take 2 years. Who can live like that?
Yeah.
And it's excruciating to thaw out. So my algorithm for treating people is talking about estradiol, encouraging them to learn about it via the ways we've already talked about it, to talk to their primary care doctor or OB. And if they're without resource, talk to me about their hormones, because I'm happy to help them with that. We always keep these shoulders moving. Our instinct is to keep them frozen to the side, and very rapidly you will lose all motion. So get them in some good physical therapy. Teach them how to move it at home. If it's just too excruciating to do that, I will sometimes put a steroid injection into a place called this subacromial space, which just bathes the entire inside capsule. I'm going to describe what the capsule is. I'll do that now. So the layers of your body are, you see your skin and the fat underneath your skin, and then you get to a muscle layer. The big muscles you see in the mirror when we're lifting biceps, triceps, lats, delts, that's the layer on the outside. Below that, you have 4 little bitty rotator cuff muscles that actually move your shoulder. And inside of that, you have a capsule. It's like, I call it the inside skin. It's the capsule. It's soft, it's billowy. It becomes so inflamed, it contracts and becomes very tight. And when I put an arthroscope or a needle scope into the shoulder to look, instead of being pure white and glistening like a shoulder should be, like think of new fallen snow if you live in a cold place, it is hot and red like a furnace inside with capillaries going everywhere because it's just so inflamed. No wonder it hurts. So if we cannot help it resolve by moving with therapy, with home exercises, with a steroid injection, I am now applying the power of the anti-inflammatory effect of platelet-rich plasma, which is your body's own growth factors housed in your platelets, to try to decrease the inflammation. If none of that works, I will take people to the operating room, put them to sleep, and move their shoulder for them. I just gently move it and the scar tissue will break up. And that's usually enough. And then they go to therapy 5 days in a row afterwards, and they'll get more than 50% of their motion back to jumpstart it. If I can't even move it in the operating room, then sometimes I do put the scope in and physically open the capsule, and it will heal back in a looser configuration. I try not to do that ever, but sometimes, occasionally we have to. So that's the full spectrum of treating this shoulder freezing. Now, I just want to clarify, because I get a lot of questions about this. Loss of estrogen is not the only reason your body hurts. You can still have a legitimate rotator cuff tear or a meniscal tear in your knee. We still can be injured, but 41% of the time when we do imaging, there's nothing structural going on. I just wanted to clarify that.
Yeah, no, I'm happy you did, because you can have the sort of primary and secondary reasons why you're having FSS, right? So the primary would be an injury, and then the secondary is what you're describing, where it doesn't, there's no trauma in the history, in the patient's history, and then there's been this slow degradation, that freezing phase where they're losing mobility. I wanted to share something with you, which I think you'll appreciate. And it's more from what I learned as a chiropractor, as a practicing chiropractor, because you might imagine physical therapists and chiropractors, massage therapists, I would assume as well, osteopaths, we tend to see before they get to a surgeon, and they might come for care to a PT or a DC or what have you. One of my mentors, when I was learning more about frozen shoulder, because it just seemed like overnight I had all the frozen shoulder patients and I did not know what to do with them.
Yeah.
So I was like, okay, I need to take myself some courses here. Some of the thinking, and I love the explanation that you're giving with the hormonal etiology potentially, and then the inflammatory etiology. These are sort of chemical mediators or chemical roots of why things are going a little awry. What I learned, and I'll share with you, and I would love your feedback on it, is that there can also be, and something like frozen shoulder, you're going to sort of have multifactorial things, more of a neuromechanical dysfunction, where there may be dysfunction, let's say, in the nerves exiting at the cervical spine, at the cranium, at the occipital atlantal joints, and then that is going to create, I'm hoping I'm doing my mentor's justice here, but that's going to create dysfunction in the way that the trapezius muscle operates, because you have those cranial nerves going to the traps. And then that's going to set up the scapula for aberrant motion. And that will set us up for like one of the first clinical signs of FSS, which is going to be that like improper positioning, or that improper like scapulohumeral motion, or that like abduction. Like usually we would call it like under 100 degrees of abduction is when we're starting to see some of that, capsulitis or that frozen shoulder taking place. And then when you have like when the scapula now can't actually set the humerus up to turn in the subacromial space, like you were saying, now you're getting compression of the tissue, and then the adhesions come, and then the second sort of hallmark again is like pain. So you were mentioning like it's the range of motion, but then it's also the pain on initiation of the motion, which is also one of the sort of clinical hallmarks. And then of course the adhesions, just you do this for 2, 3, 4 years, and then you develop these adhesions in the capsule. I wanted your initial thoughts on that. Yeah.
I think it's interesting that you brought that up, because it's normal to protect themselves. What people don't realize is that all the nerve roots that feed your entire shoulder and arm come out of your cervical spine, right? So at every level, there's an exiting nerve that travels varying distances down your arm. So the high nerves that innervate high up in your neck into your traps, which the Bettys probably know this, but my people may not, is this muscle right here. If that's inflamed, or the nerve is firing in we call it radicular, in a stinging matter, it is normal for you to do this to protect it. You don't want to have it hanging down. You want to do this. Well, do this for a week. That shoulder is so sensitive. Doing this for a very short amount of time will limit the motion in your shoulder. And so when I'm trying to help people understand the origin of their pain, it's not always your shoulder. Sometimes it's your neck, right? And you just have to go down that pathway with people. Are we treating the neck? Are we treating the shoulder? Or are we doing primarily neck and now shoulder, because nothing's moving? The scapula's stuck on the back of the thoracic spine.
Right.
Yeah. So interesting you brought that up. I don't get to talk about that very often.
I thought you might not, and I thought you might appreciate it because I think there's so much overlap in terms of your body of knowledge and my body of knowledge and our shared clinical experience. But I love, I would say this all the time in practice. People will come in with, let's say, they'd say, my shoulder hurts here, It's
right.
like, well,
not your shoulder.
Not exactly your shoulder, but let's take a look at your neck, right? And let's take a look at the mobility, active, passive range of motion. What is your capacity to turn? What's your capacity to laterally flex, extend, etc. And people would be shocked. We would direct care at the neck and their shoulders here and sometimes here but also I'm pointing to my traps for those that are listening on audio.
Traps.
So people would have pain in their traps, but because of that radicular pain that you were describing, the nerves that are coming off of the cervical spine and going into the upper arm were being affected. So they were either being crushed at the exit point at the joint or somewhere along
distally.
Or distally, exactly. So maybe let's talk a little bit about muscle mass, because frozen shoulder is something we know affects both men and women, a markedly higher incidence in women.
Yes.
Are there strategies that a woman in her 30s or 40s might be thinking about where she can say, okay, I want to be able to preserve my range of motion. I want to be able to set my shoulders and other articulations up. So it's not, frozen shoulder is the most obvious because, as you said, like the Apley scratch test or like the unhooking of the bra thing, doesn't happen. So are there things that we can start putting into place as a 35-year-old, as a 45-year-old woman that you think are impactful in preventing or at least lessening the incidence or the severity of frozen shoulder?
Well, I love that you bring this up because I do a whole series for millennials who are now 43, right? And so 110 million people and 51% will have to talk about these things. So it's really important. So as a 35-year-old, full of estrogen, full of youthful vigor, still able to maintain bone density and muscle mass, I call 35 to 45, pardon me, people, the critical decade to get your shit together. Because I know, I'm so sorry. I'm an orthopod.
No,
we talk this way. Yeah, it's time. So I know you're busy with your careers. I know if you've decided to have children, you're hot in the middle of little people. But now's the time to learn. So now's the time, pick up Estrogen Matters so that you can know ahead of time what you're going to need. Now is the time to eliminate simple carbs from your life and focus on fiber, so that when you do become highly inflamed, that's not another addictive battle you have to deal with. Number 3, get into an anti-inflammatory lifestyle, not just food diet, that includes building lean muscle mass. Make it such a part of your life, one activity at a time, that it's not so harrowing in midlife to start it all at one time, right? Oh my God, how do I deal with menopause and loss of muscle and loss of bone? And all the things won't be quite as hard if we get menopause literate, midlife literate, and start layering on. Maybe you do nothing about it right now, but you have the years to layer on education. Then you start walking every day in zone 2. Then you add, now that I am mobile every day, now we're going to learn how to lift weights. I'm getting too animated. I'm knocking my computer off. I know, I get so passionate about it. Now,
I'm so excited. I love seeing you get this excited. It's awesome.
Yes. Now we're going to go to the gym and we're going to learn to lift so that when you get to midlife, you can lift really heavy, because that's how you're going to stimulate muscle protein synthesis and satellite cell reproduction. So that you see what I'm doing, instead of when you're 49 or 52, you're like, oh my God, I've got the whole world to do. You layer on year after year, so it's not so hard. Totally prepared. You'll know your body. Your joints will move. You'll have the muscles to support it. When you start getting stiff or having brain fog, hot flashes, night sweats, all the things, you're like, perimenopause, let's go. You're going into known territory instead of entering a wilderness that you know nothing about. That, to me, is what the critical decade is all about.